the regional lead for palliative care at Vancouver Coastal Health, but I've also been co-leading the Vancouver Coastal Health Advanced Care Planning Initiative. And really, this initiative has spanned several years, and I've co-led it with Darren Kopetsky, who is the Vancouver Coastal Health Client Relations and Risk Management Lead. So, Deanna, I'll ask you to introduce yourself. And I guess I should also add that I am one of the co-investigators with iPANEL. And so that is why I'm one of the people presenting on this relationship between iPANEL and the role of the nurse in advanced care planning.
That's right. Thanks, Pat. This is Deanna Hutchings. So I'm phoning in from Victoria, and Pat's calling in from Vancouver, and we organized this in Kelowna. So just so you know, it's a multi-site perspective. I'm, like Pat, I'm a clinical nurse specialist in end-of-life care for VIHA, and again, like Pat, I'm the chair of our regional advanced care planning working group. So I had been living and breathing the notion of advanced care planning for about a year now. And like Pat, I'm also a co-investigator on iPANEL. And so we've had a lot of time to think about the relationship between these two important, one being a research project and the other being an initiative in the province. And we'll be talking more about those linkages today. Really glad to be here with you. And perhaps I'll just sneak in the statement that this is Pat Porterfield's last day. So we're lucky to have Pat leading this with us today.
Yeah, thanks, Deanna. I'm actually retiring as of the end of June, but this is my last day at work today. And I will, though, be continuing on with the iPANEL work. So I don't feel the need to say goodbye to everybody. I will be still staying involved in lots of activities related to nursing and end-of-life care. So with that, we'll begin. And so our first slide then, the first number of slides, about 6, really relate to iPANEL. And if I know that some of you have probably been coming to these iPANEL's presentations that are scheduled on a monthly basis. So we do apologize that for some of you that know the iPANEL work well, this will probably be a bit repetitive. But for those of you who are new to iPANEL, we always like to introduce what the heck iPANEL is. And maybe going back to the previous slide, one of the things just to reinforce is what the initials stand for. So iPANEL stands for an initiative for a palliative approach in nursing, evidence and leadership. So why those of us who are involved with iPANEL got involved are really captured in this background slide, because we are now facing in Canada, as is the rest of the Western world, looking at a number of people facing old age where it's really important that we start looking at supporting the care. Sorry, I flipped that slide. Where we need to start supporting the care of people with serious chronic illness and life-limiting disease. A century ago, people died around age 64. Now people are living into their mid-80s. But what does that extension of life mean? Well, we know for a lot of people it means a real healthy, active life as a senior. But we know for others that it can mean years of disability and sometimes suffering. And so we need to make sure that we're doing a really good job, that when we're extending the years, we're also extending quality of life and doing the best that we can as a system for those folks. So the other challenge with this is that these individuals with life-limiting serious illness do not spend their time accessing palliative care service. We recognize that palliative care services that are specialized services are really focused on people where we have a definitive diagnosis and we know that we are in the last months of their lives. So for many of these people that are living with chronic and life-limiting illness, it is more a case of dwelling in what we call this indistinct zone of chronic illness that has up to now not had a specific care delivery system. And I do want to acknowledge that we know that lots more work is going on in the field of chronic illness and chronic disease management. And so much of what iPANEL is doing is going to link with other initiatives as well, that being one of them. So the palliative approach, which is what we're really wanting to try to understand how this palliative approach could help this population, takes principles related to palliative care and looks at the application of them to the care of people with life-limiting chronic illness or chronic conditions. We know that we can't provide care to that group exactly the way that we provide care to those who we know are definitely dying and are moving into the final months of life, where there is a real focus on preparing for death. We know we have to do things differently with the palliative approach, and we can't link it as closely with prognosis. So we need to start talking more about quality of life, how people want to live years, not months and weeks, but include some of what we know about how to do good symptom control, how to look at, well, what is meaningful for you, not in the last months and weeks of your life, but in the last years of your life. What's really important for you at that time? So those are the kinds of things that we are wanting to understand better when we're developing this palliative approach. So I think in a sense, this next slide, I'm on slide 4 now, I think I really have kind of captured that in my previous comments, that we need to really focus on quality of life and relief of suffering. And early identification of patients for whom the palliative approach would be helpful is a really important piece of this, as well as assessment and then knowing how we can intervene. So what iPANEL is trying to do, because this is new work. We have actually been doing some really interesting literature searches about palliative approach in chronic life-limiting disease. There's a lot written about palliative care, but much less so about this palliative approach, trying to take these principles to these other populations. So we're really looking at how we can use research, both through knowledge synthesis and new research about how nurses can further integrate these palliative philosophies and services into non-specialized settings, because we know that most of you are not working in specialized palliative care settings, but you can see this population and you're concerned with the care that we're providing. So the cycles that we're trying to engage in are working with practitioners. So it's really important to iPANEL that we have partnerships with practitioners. And in this case, Deanna and I have both come from the practice setting. We're not nurse researchers. We're not academics. We're people that have been working in practice. And a number of members of the iPANEL team are like us. So we're privileged to be able to work with skilled researchers, Kelly Stadjahar and many others. But so the partnership is really looking at the cycle of nursing practice to research and back again, and how we can inform clinical practice. That leads to the next slide, which is now moving into probably the topic that most of you were tuning in to listen to today, and that is about advanced care planning. So advanced care planning is really the process of a capable adult planning for how they are going to give consent to health care when they lose capability. And it isn't a one-time thing, it's a process of learning, deciding, talking about, and documenting or otherwise expressing what it is that the adult would want in the future. What's really important, and what's you'll be hearing more about this today, is that it must be consistent with healthcare consent and the new healthcare consent legislation that we have in BC. So why is iPANEL interested in advanced care planning? Well, I think, there is tremendous synchronicity between what iPANEL is interested in learning about in terms of how we can serve the population that we were discussing, that I described earlier, better, and what advanced care planning can do. So we've pulled out a couple of what we see as being shared elements, but I think that you could probably identify other things as well. Certainly, iPANEL, or palliative approach, recognizes that one is approaching the end of one's life. Not necessarily imminently, perhaps in years, but there is this sense of life being finite and that we need to be planning for it. True for advanced care planning as well. Again, advanced care planning can be done at any stage of adulthood. You need to be 19 in order to engage in advanced care planning. But we know that people become more interested in advanced care planning as they move into their senior years, as they start to live with a chronic illness. So we're talking about similar patient populations and an acknowledgement that indeed life is finite. And for both the palliative approach to be successful and for advanced care planning to be successful, we have to identify clients who could benefit from both of these activities early enough to engage with the clients to do this. And when we start to do advanced care planning and look at the values and beliefs that are guiding people's wishes about what they would want with treatment in future, for example, life-sustaining treatments, you know, it's the same kinds of conversations that we have when we're starting to talk to people about a palliative approach and quality of life. It's, you know, what is important to you? You know, how do you see yourself living in your final days? What does it mean to you to be at home or elsewhere? All of those kinds of things that come up in conversations. So, so it's a similar focus to the discussions. Of course, advanced care planning is going to move off and move into this area of future healthcare decisions, and the palliative approach may move into then talking more about what would make you more comfortable today, and move into talking more about symptom management. But the basis of that conversation in terms of understanding the person and their values and beliefs is the same. So I've already flipped to the next slide, which is about the rationale of care planning. And some of this is, you know, these are familiar themes from the background to iPANEL. It is based on this same notion that we're living longer with more chronic illness. And we anticipate that a number of people are going to have cognitive loss near the end of their life. And I say that particularly because we're aware of the rising number of people that are going to be living and dying from dementia. So that's a significant population that we really need to think about how we can serve them best through advanced care planning. But regardless of whether somebody has dementia or not, most people have some period of time prior to their death when they're not capable of making their own healthcare decisions. And so with the advances that we've got in science and medicine, that we are able to do things, we're able to extend life. Sometimes it may feel to people that we're prolonging the dying process and not necessarily adding quality to it. So what we need to make sure is that we use these life-sustaining treatments in the best way possible. One of the biggest problems we have in terms of these conversations is that we've tended to be a society that has seen you know, death as a rather taboo topic. And I know if any of you have worked in end-of-life care, that's one of the things that we've always said, you know, one of the biggest challenges in providing good palliative care has always been this knowledge that, or not knowledge, but this sense that society sees death as taboo. And it's certainly one of the barriers in terms of advanced care planning and in terms of us introducing the palliative approach. So there's some research that gives us confidence that Canadians are interested in advanced care planning. And the article that's up right now is one that was done by Singer, and it's an article that's quoted a lot. And we use it as an article that gives us an idea about what's important to people in terms of end-of-life care. But it also is an article then that gives us a notion about the fact that people do want to be engaged in advanced care planning if they want these wishes to go forward. And the areas of importance in Singer's study, and he used dialysis patients and patients in residential care and renal patients, I believe, in this study. Deanna, I don't know if you want to comment, but I think those were the patient populations.
I think so too.
Oh, it may have also been, because I said dialysis and renal, and those are the two groups. I think it was also HIV AIDS patients as well. So there were a number of client groups that he included in this work. And what they said in terms of areas of importance, well, one was to trust and have confidence in the doctor that was caring for you. But the other issues are certainly ones that are important from an advanced care planning perspective. This notion that people didn't want to be kept alive on life support when there was little hope. The concept that they wanted to understand about their disease in an honest manner. And we know from the research that we've been doing about advanced care planning that actually knowledge of prognosis is important to people in terms of starting to embark on their own advanced care planning, and particularly if they're wanting to get into more detail about how they might want their chronic illness managed, that they really do want a sense of prognosis, and not necessarily a specific number, but a sense so that they can start to do more realistic planning for their lives. That they want this sense of being able to complete things and prepare for life's end, which again relates to this concept of prognosis and planning. They want to have an adequate plan of care and the services available. And I know we all hear the next one a lot, this concept of people really not wanting to be a burden to their loved ones. So as much as possible, people do want to do this planning themselves and leave things laid out for the people that they love, so that the burden of decision making isn't going to be on those people, but also they want to know that help is available so that the burden of care isn't on their loved ones as well, or at least a shared burden of care, that their loved ones will have support in caring for them. The next study that I want to introduce you to is called the ACCEPT study. And this study is one that's underway right now, and actually Vancouver Coastal Health and Fraser Health are both participant sites in this study. The findings that I'm going to be sharing with you, and the folks that are the participants in this study are patients and family members, the patient being either over 80 or 55 years old and living with an advanced chronic illness. So again, very, very typical of our population that we're concerned about from an iPANEL perspective, but also a population that we're very concerned about from an advanced care planning perspective. And so what we found was that these patients or family members were asked, had they thought about decisions around life-sustaining treatment, and we asked them whether they had thought about this both before they went to hospital. The study was actually done in hospital, and so then we asked them whether they had engaged in any of these conversations while they were in hospital. So the study kind of reports findings both in terms of the pre-hospital and the hospital experience. And I'm only just sharing a couple of the findings with you today. But one that I find really interesting and very encouraging from an advanced care planning perspective is that more than 75% of the patients and families had thought about the care they would want in their final stages. And more than 90% of these had already discussed these preferences with family members. But less than 30% had discussed these preferences with their doctors. So I think what we're learning from this is that this is on people's minds, but perhaps we haven't had the courage as healthcare providers to raise the subject with them. What we also learned in this study is in terms of what people want in conversations around end-of-life care to help inform their decisions, and the things that they want to understand better or that they felt that they were dissatisfied with in terms of the information that they got were discussions around location of care. What are the choices and what does it mean to be in these different locations? What to expect in the future, which was really around their disease progression and prognosis. And what does it mean when the care would be oriented towards comfort measures? What does that mean that I can expect in the way of my care? So that also gives us information as to what's going to be important to include in our conversations when we're helping people with decision-making in advanced care planning. And at that point, I'm going to turn this over to Deanna, and she will pick it up from there. Okay.
That's right. Thank you, Pat. So we'll progress on down this pathway, and we'll talk a bit about what does the advanced care planning process actually look like before we get into some of the legislative elements to this. So we're operating on the basis that a key reason why you've signed up for this today is you want to have a sense about what's involved and where do you as health professionals fit in with this. So a strong focus of the Advanced Care Planning Initiative is really to get the dialogue going. You may recall that the national campaign is called Speak Up. It's about us encouraging our clients, our family members, our community to be talking about these issues, to open the dialogue. And I guess I could say, in listening to Pat's the frame on the ACCEPT studies, it's encouraging to learn that 75% of those people have said they've been thinking about care they might want at end of life. So it's getting the conversations going. It also means, of course, that the public needs to know more about their own disorders, their own health status within the chronic disease that they have, learning to ask the questions, learning to become informed about their own particular disorders. Exploring the options, as the previous frame described, knowing more about what might be available, what might be offered in terms of the kind of disorder that I have. What do I need to prepare for or think about? And then another key element will be for encouraging people to think about who will be your decision maker for healthcare decisions when you can't. It's important to realize that we could all face either temporary or permanent times when we're not able to make healthcare consent decisions, and we need to have someone determined at that time who can. It's about encouraging people to think about what their beliefs and values are about quality of life, encouraging people to be thinking about and beginning to articulate their beliefs and values about what quality of life means to them. And then talking more. I think we put this in to highlight the fact that these are not one-time conversations, particularly in a person's explorations of this themselves. It's quite circular, isn't it? You talk about it. You talk about it with, say, your healthcare team. It might be home care nurse. It might be a nurse practitioner. It might be your primary physician. You think about it. You do some learning, and then you come back and you have the conversations again from a more informed position, or beginning to know what your questions are in a clearer way. Encouraging people to begin to write down what are some of their wishes, their values and beliefs. And that does not have to be in a formal sense. It doesn't have to get it written in stone yet. It's like priming the pump, getting these thought processes going. And then, at a more formal level, if a person is ready to, appointing a decision maker. And when we say appointing, that's when the capable adult is doing the appointing, right? Because while we're capable adults, we have the ability to appoint a decision maker through means of a representation agreement, and we'll get into that a little further, or making an advance directive, which is another means by which a capable adult can indicate what they would or would not be prepared to accept as a health care treatment. So here, folks, is the nugget of it all. This is a statement lifted directly out of the legislation, meaning Healthcare Consent and Care Facility Admission Act, and this is the nugget of it all. So as we learn this, we know that everything else rolls out from this, and it is that every capable adult has the right to give, withhold, or revoke consent to health care. I can say yes, I can say no, and I have the right to change my mind. And that's the fundamentals. Even advanced care planning is about how to determine who and how we'll do that, either give, withhold, or revoke consent in the future when I'm not capable. So advanced care planning takes that and moves that into the future. So here we are in our next slide, and it's about the legal framework. Now, the legal framework comes right out of that legislation I just named and described. We've got it there for us, and it came into effect on September 1st of last year. To back up the train a little bit, it isn't the first time healthcare consent legislation came out in BC. The first legislation did come out in 2000. In our various health authorities, we had various degrees of information around that. Some healthcare teams are more aware of that than others, but by and large, it hasn't been really widely understood. Then effective of this in September 1st last year, there was some fine-tuning, and we'll talk a bit about the fine-tuning when we get into one of the elements of substitute decision maker. So what we're going to look at here, and what the legal framework looks at, is who consents to health care for me as an individual now, while I'm capable, who consents to health care when I'm not capable, and when I'm not capable, what are the bases on which those substitute decision makers base consent to decisions on my behalf? And how do I express my wishes for healthcare, and what tools are available? Recognizing we only have about 15 minutes to do this, I acknowledge that this is a whistle-stop approach, but I'm hoping that it gets you started, or perhaps you've already had some education in your own health authorities, and this is a repeat, and if so, that's good too. But this is material that I think lends itself well to repetition. So the first person who has the right to consent or refuse health care is always the capable adult. If we have a capable adult in front of us, that's who we turn to. They can have all the legal documents in the world, including sitting on our charts, but if they're a capable adult, that is the source of consent. However, if they're not, here we are in ranked order. The first is a personal guardian, also called a comité of person, and that person actually is appointed by the court. That is a very strong and absolute decision maker. The powers are granted to that person for that. I would acknowledge that you're not going to see that a lot of the time in your practice. It is it's the root of the last attempt, because it is costly and it takes away a great many powers actually. However, where it exists, it trumps the others. That's the piece we need to know. Next is the legally appointed representative, and it's the capable adult who has the right to do that. And they can appoint anybody. It doesn't have to be family. They actually get to choose. And if you use a representation agreement, it's legally appointed. Whoops. No, we're not quite ready to leave that one yet.
Didn't quite mean to do that. I'm sorry.
Yeah, okay. Next is, and you know, this is where you'll often be dwelling, unfortunately, as healthcare providers, is in the land of the temporary substitute decision maker, because if you don't have the first two and you have an incapable adult, you do need a decision maker for healthcare consent for treatment issues, and that's the category we'll turn to. We'll name them shortly. And lastly, in an emergency, healthcare providers have the capacity to make decisions under some circumstances. And I think now we're probably ready. The personal guardian, also called a comité of person, as I said, it's court appointed. The legislation that governs it is the Patient's Property Act, and that personal guardian can be drawn from a range of potential persons, including family or friends. It needs to be people who apply to the courts for that designation. And as we said, it is a last resort and most intrusive and costly. Nonetheless, if someone says they have a comité of person, we want to know about that. We would ask for a copy. We'd put that on the chart, and we need to make it very clear that is the source of consent. Next is the appointed representative. I talked about it's the capable adult makes that decision. Doesn't have to be a family member. A quick example would be, you know, when we give presentations and we talk about substitute decision makers, you're going to see, as we talk about the TSDM, the temporary, that one's adult children, they're all equal. There's no ranking about your adult children. So if you have 5 daughters with 6 different opinions about what probably should happen to your future health care, you might not want to leave it to chance. You might want to decide there's a particular family member who fully comprehends your wishes, or you might even say to yourself, I'm actually going to make it my sister. I don't want any of my 5 warring daughters to be doing this. So the adult gets to choose. There are 2 types. A Section 7 agreement, a rep agreement, is not the one that we're going to see most of the time, and the reason is the person that's appointed by persons not fully capable, and it was initially designed for persons with developmental delays. So if you think of it in those terms, then that makes it easier to understand that by and large you're looking at, you want Section 9 rep agreements. That's one that the capable adult makes. As of the new legislation, you may know that it became more accessible to the public. Previously, representation agreements had to be done by either a notary public or a lawyer. They no longer do. We can take them down off the web. We have to have 2 witnesses to sign them, but they can be done by the capable adult without a lawyer. If one of those witnesses happens to be a lawyer or a notary public, you only need 1 witness. Now, here's where you'll often be placed, I think, in healthcare, and that is we'll frequently have a situation where there is no representative that's been legally appointed, there is no advance directive, and we're going to be faced with searching for a TSDM. They are a temporary substitute decision maker. Yes, they've got to be over 19, and they're appointed by whom? By the healthcare provider. They're not appointed by the adult, because by that time the adult's considered not capable of making that decision or comprehending the significance of their decision. They've lost their opportunity to appoint somebody, so now the healthcare provider has to appoint on behalf of the incapable adult. And they're selected from a ranked order of persons, which we'll get back to shortly, and that ranking order is set forth in the legislation. They also have to be willing to carry out the duties. That's okay, Pat.
I'll go back. I get excited here.
Go ahead and move us on then to, we'll look at the list because, you know, it's a very important thing. So here's the rank. Spouse. They trump the other decision makers, right? Spouse, that comes first. Adult, child, parent, brother, sister. Everything that's in red here is the new ones that have come in courtesy of the legislation last year. You'll notice that it broadens the net considerably, and it takes us even down to a close friend. So, for example, you know, Vancouver Island Health Authority includes the Gulf Islands, and it includes remote areas in Souk. We have sometimes reclusive people who live in these areas. They have sometimes made decisions not to have connections with family anymore. They actually may have nobody in those above categories, but maybe they have a neighbor with whom they have had an ongoing connection with for the last 15 years, or somebody in the community has sort of kept tabs on them and is the one conduit that still sees them. Well, if that's the case, then that kind of person would fit now under close friend and would be in a position to represent them as a TSDM in the absence of the above. So, in terms of adult children, you'll see there that there is no ranking order. And so that will be where there will at times be consensus and at times there'll be conflict. And it certainly, as the public learns more about this, I think it helps illustrate to them why it might be wise for them to actually make the decision themselves about who they wish to appoint. And that moves us on to the next one. There are some requirements. They've got to be 19 or older, capable themselves of making the decisions. They have to have been in contact with the adult in the last 12 months. So we cannot be estranged or had no contact for 5 years and then be expected to make healthcare decisions on their behalf, because clearly that might not be somebody with whom the incapable adult has vested a lot of trust or exposure to their own ideas. There has to be no known dispute. And they have to be willing and able to carry out their duties, i.e. to represent that person's wishes. So having said that, we would just actually stay with that for a minute, although, yeah, having said that, it could be that a spouse, perhaps if he or she is elderly or is feeling totally overwhelmed by a particular situation, if they're the first in line for TSDM, they certainly have the right to say, I don't feel up to this, but, you know, I'm going to assign my son or my daughter to make these decisions on my behalf, and they can do that. Moving where we are, their duties, the duties are actually set out in the regulations, and it's important to know these for those circumstances where at times you may find that you don't feel that they'd be carried out. So what are they? Well, that person has to make decisions around giving or refusing consent based on the adult's best interest. That would include their current wishes or known beliefs and values, and whether or not their condition is likely to be improved by the proposed health care, and whether or not it would be improved without the proposed health care. The actual decision-making process is the very same as we would run past informed consent past an adult. What will happen if we do? What will happen if we don't? What's the impact on the person? What would result in their well-being? They need to be thinking about, is the adult expected to get benefit from the proposed, or is there a risk of harm? Is there a more less restrictive means? So moving on to thinking about that ourselves, take a minute for your own self and ask yourself, if I don't have a rep appointed, and you know, we don't all, it's fairly new that this has been available to the public without lawyers, reflect on that hierarchy, that ranked order that I just described, and ask yourself, Pat's taken us back there, reflect on that order. Okay, and now if you'll take us back to 22, there we go, and say to yourself, who would likely be, who would a health provider likely have to turn to in my life from that list? And do I think they know what my wishes would be about life-sustaining treatments? So we're asking you to think about that in terms of yourself. And then if you've already put up your participants dialog box, you'll see that there's a raised hand on the lower left. You just click that, and that is where you can respond to this question. So if you feel yes, a potential TSDM in your life would know your wishes about life-sustaining treatment, then you respond with raising your hand.
Well, yes. I would say we have at least 15. And, of course, some of the sites have got a few people, like many people on them. So.
All right. Okay.
Yeah.
Okay. Thank you. And so bear in mind how you did that, folks, because you'll be having a chance to raise your hand again throughout some of the subsequent slides. I think that takes us over to you, Pat.
Okay, and you know, because we have the case study, Deanna, and I really want us to have time to talk about that, and it's 1:45, I am going to really abbreviate these comments about the advance directive. So I'm going to scoot through the about 5 slides in about 1 minute here. The advance directive is a new tool that came in September, and the difference between that and the previous advanced care planning documents that we had been using, perhaps in your health authority, I know Fraser Health had the My Voice document, and we had started to use that in Vancouver Coastal. Those were wishes, values, and beliefs, but they might also give some pretty clear ideas about what you would want in the way of life-sustaining treatments, whether you would want dialysis in this particular circumstance or you wouldn't. But those were always directions to substitute decision makers. So the biggest difference, well, the difference with the advance directive is that it is a document that once you complete and write down these wishes, for example, I'll use dialysis again, that I would not want dialysis continued if I was unresponsive with no or less than 90% possibility that I was going to regain consciousness again. So that might be my statement in my advance directive related to dialysis. So that statement can speak then directly to the healthcare providers. So if I was to arrive in an emergency or an ICU with that kind of a statement, and they identified that I had renal failure that was not reversible, was likely going to worsen, that they would not continue dialysis or would not initiate dialysis in that situation. Probably in the advance directive I should indicate I would not want it initiated or continued. So the clearer that people can be in advance directives with their wishes, and they have to describe what the instruction is in terms of the consent situation, whether they would or wouldn't want the treatment, and the circumstances in which they would want that instruction applied. In other words, you know, is it a situation where it's irreversible and approaching end of life, or just, you know, any situation? Most likely people aren't going to state in any situation. The one thing that I can think of that some people might have in any situation might be an OCPR order if they are, you know, in their 80s and they've determined that they wouldn't want CPR under any circumstances, or sometimes people are approaching the end of their life living with a life-limiting illness and they've decided that they wouldn't want CPR in any circumstances. So those are the kinds of instructions that we're expecting to see in advance directives, but it's a new tool, and at this point I have to say the only ones I have seen are the ones that are from other provinces. I actually haven't seen one that's a BC advance directive as yet. We're going to give you resources at the end of the talk that give you where the new provincial guide in terms of my voice and expressing your wishes around healthcare decisions. It has the form that can be used for the advance directive. You don't have to use that form, but it's better because I'm going to move on to talking about what are the requirements, and the form that's in the new My Voice document really helps you achieve these requirements about being completed by the capable adult, to make sure that it doesn't have any instructions in there to do anything that isn't permissible by law, to give direction around the witnessing, and also the form that's within that My Voice guide also has these two statements in it around to ensure the person's understanding of the effect of the advance directive, that specified care may not be provided, and that no other decision maker may be asked to join the decision. The one situation where a decision maker would be asked to join is if you had a representative, then they would be the person asked to interpret the advance directive in conjunction with the healthcare provider. So I think that the final thing that I'm going to say about an advance directive is the comment that's up on the screen now, that if you want to ensure that the advance directive holds in spite of changes in medical knowledge, practice, or technology, then you must state that in your advance directive as well. So I think having whipped through those slides, Deanna, I'm going to ask you to pick it up, and I'm just going to move here to implications for nursing practice. So what we've been whipping through, and I feel like I did really whip through the advance directive, but what we've been whipping through in terms of healthcare consent and advanced care planning, I just would like to summarize what we really see as the important things for nursing practice, what we need to take away. We need to understand this to be able to support patients and families to know more about advanced care planning, to be able to support healthcare decision-making on behalf of capable and incapable adults, and then to support their substitute decision-makers in their role. And we've kind of summarized what we think are the essentials for nursing practice in this next slide, the ASK slide. The A stands for asking. Has the patient thought about future healthcare decisions? Have they done an advanced care plan, as in wishes, values, or beliefs? Have they done a representative agreement? Have they decided to do an advance directive? And if they have done that, we need to know what's in those documents, and then we need to ask them if they will share them with us as healthcare providers and our both ourselves as healthcare providers and our organizations, and we need to store them appropriately within our organizations, or if it's the person, then they need to encourage them to store them appropriately within their own home as well. And we need to know what are our resources, both in terms of the materials available to the public through the ministry, which we'll share with you at the end of this presentation, and what we have available in our own health authorities. But we also need to know what are resources to help us give better guidance to people in terms of advanced care planning. And now I think we have a case study that we can share.
We do. We're going to quickly take you through this case study. I'm mindful that there is just 10 minutes left. It does allow a bit of opportunity for you to indicate some things with yes, no through raising hand, but we also have one, if not two questions, whereby we'll open it up to your dialogue so that we get some of your responses. So this is a situation where Mr. Q is 77 years of age, and he's required hemodialysis now for 3 years. Concomitant difficulties, he's diabetic and has been for 20 years. He lives with severe neuropathic pain. His surgeon recommends a right foot amputation, or below the knee amputation. And as a nurse, you're talking to him one evening or during a dialysis run, and he says, you know, I just don't know if I want the amputation. I'm thinking about stopping dialysis. I'm not sure how I'd manage with one leg. How will I manage at home? I don't think I'll be able to do the things I enjoy anymore. So that's what you hear. So here's some of what you face. This gets you thinking. From your current, what little you've heard there, does he sound like he's capable to you? Raise your hand on our click if you think yes.
Yeah, lots of yeses.
Lots of yeses. Okay. We know that there's room here for exploration. We can't fully respond to what he understands about diagnosis and treatment options or risks and benefits, but what we're offered here is a springboard for discussion, aren't we? It's an opportunity to explore here so that you can gather a better understanding of what is his understanding of the potential, not just the treatment options, but the potential. And then there's an opportunity, A, to listen, and then B, to provide some more information. We'll move on to number 3 here. Do we know yet what is important to him? Do we have a sense of what are his values and beliefs? And give us a raise your hand if you think we do. And we'd acknowledge that, of course, there's room for more exploration here. We might know what some of his stated values and beliefs, but it's a chance for us to offer him opportunity to talk more about those things, and in so doing, maybe to clarify them more for himself. So what's your ratio of raised hands there, Pat? Is it a goodly number?
Quick. I think, yeah, I think people are feeling that we're getting a sense of his knowledge and beliefs, yeah.
Mm-hmm. Yeah.
And
I would acknowledge
it's not
it's
values,
never full.
Values and beliefs, yeah.
Yeah. Has Mr. Q talked this over with his family or with other healthcare providers? Do you have a sense that he has? If you do, raise your hand. And if you don't, perhaps again there's opportunity for more exploration, and that can shape the dialogue. Who else on the healthcare team needs to be involved? So you're the nurse, you're thinking about this. What other ideas do you have in terms of who else could he be speaking to? Who might provide information that will assist him to have a better sense of who that might be? I'm going to use the chat box here. I'm going to send something off. Oh, yeah, we've got some rolling in. OT, social worker, a palliative liaison, his family physician. Fair enough. Great.
Yeah.
And moving on to 31, because I think we're going to proceed this. Yes, we're going to stay with Mr. Q, and we are 2 weeks later, and things are changing. He's taken a nasty fall at home, and he's found by his landlady. So he comes in to emerge via ambulance. He's not accompanied with anyone, and the diagnosis is that he has a subdural hematoma, ostensibly from the fall, and he's now confused and uncooperative. What little we know is that he does have a son in Calgary, but he's estranged. He has a grandson who lives in town. Now, is he capable of consenting to the needed treatment at this point? Click the raise your hand if you think he is not.
Lots of hands are going up.
Lots of hands. Mine too. I hit that one myself. Okay. Moving on. So, at this point, who can provide the consent for treatment of the head injury and for hemodialysis? Is the son the TSDM that a healthcare provider is likely going to appoint? Raise your hand if you think yes. And moving us along, Pat?
Well, I think some people remove their hands from that. I think there's a few hands on here, but I'm not sure if it's just that people haven't had a chance to take them away. But I think this is a really good point to discuss, Deanna, in terms of the son's suitability.
Ah, you know what? We've got someone put it on the chat. Good for you. Right on. So, grandson, if in contact. A couple of people on the chat line are saying this.
Yeah.
Absolutely. And the key there is for us not to get caught up on the fact that the son would necessarily be next, because he doesn't fit the criteria, does he? There's not a current ongoing relationship with the son. They are estranged. Therefore, following the ranked order, we can approach the grandson. We don't know if he's willing, but he's definitely the next one who has the right to be appointed. So if we think about would advanced care planning have made a difference in this case, we can explore here, you know, would we have more instructions, more guidance, if he had a chance to think about his future health care and maybe to have communicated it. If he had decided, perhaps, in advance who would make his decisions if he were unable to do so, again, that would help your decision makers. So as we look this through, we'll encourage you to unmute now so that you can answer and tell us when you think would have been a good time to introduce advanced care planning. Because there's a range of opportunities here, isn't there? When would you be encouraging in that scenario or prior for discussions? You can, if you unmute, you can go ahead and speak. You unmute by just pressing your mute button. When he met with the surgeon, that would be one sentinel opportunity, absolutely. And then here's another talking about earlier in his trajectory, at the beginning of his chronic illness. With a change in health status. So another sentinel time might have been when he came on dialysis, or maybe when he's 2 years into dialysis and we begin to see changes. Yes, when there's an exacerbation of an illness, when there's a new sentinel event, those all make for points on the trajectory whereby it's a transition point at which we might want to raise those issues. Okay, Pat, taking us to number 33, because we're very close to the end of our time here. This sums up, in a way, it sums up the ask, and so think in terms of the acronym EXPRESS. We're encouraging the conversations. We're exploring beliefs and values with people. In terms of people, we're identifying who the adult needs to talk with. That might be identifying people on the healthcare team. It might be identifying people in their personal life. Reaching out and having conversations, expressing those wishes in a document if they're ready to do that. and then sharing those documents with not only the physician but the substitute decision makers, and then seeing that those documents are available to a healthcare team if you're in an acute care episode, and storing those documents in an accessible place. And then we'll move on to the resources, because it's already 3 o'clock. Oh yes, pardon me. Our key messages is that advanced care planning is grounded in healthcare consent and the legislation that sets that out. Honoring the wishes of the individual, that is the core of it, isn't it? And that it's everyone's responsibility. It does not belong to any one discipline, does it? It isn't just about physicians. It isn't just about social workers. It's everyone's responsibility to listen for the cues, to explore, to have the knowledge to guide people in the right direction. And we've put here that it's part of the path to living and dying well. We say that partly because, you know, there's a saying that we're all on this planet to walk one another home. And advanced care planning is a way of us knowing how do we walk people home. What is it that people would want in their path? Here are the resources that we've assembled for your information. Federally, as you know, there's the Speak Up campaign. Really good stuff now on the provincial websites. Both Seniors BC, but also now HealthLink has just put fresh material on, very, very workable, easy stuff to follow. And I think there's a second resource page, isn't there, Pat?
Yeah, there it is.
There we go. And the Ministry of Health. On there you can find the My Voice booklets. And there's also a really helpful document for all of us as healthcare providers called Healthcare Providers Guide to Healthcare, and it's on the Ministry of Health webpage. It's also on all of our own health authority web pages as well.